Good morning, everyone. I'm Stephanie Wilson from the University of Calgary, and I'm a CEUS enthusiast. I'm also the co-president of ICUS and a long-standing member of the AIUM. And so this is a first venture for AIUM and ICUS to present a CEUS educational webinar, and we're delighted that you have all joined us. So my presentation today is on liver imaging. Why CEUS? So in this presentation, I'm going to use brief case presentations with emphasis on at-risk patients for hepatocellular carcinoma. And the endeavor is to show the most significant benefits of CEUS. And this includes dynamic real-time scanning technique, use of a purely intravascular contrast agent, a focused nodule-based exam, and an exceptional subtraction technique. And this allows us for clinical outcomes to predict malignancy, to provide the diagnosis of liver tumors, and very importantly, for resolution of indeterminate MRI, including resolution of pseudolesions from arterioportal shunts. So let's start off looking at two similar risk patients, which we'll call patient 1 and patient 2. They're both 55 years old. One is a male and one is a female. They both have chronic hepatitis B viral infection, making them at risk for HCC. And they both have a lesion found on surveillance ultrasound. So let's look at our two patients. On grayscale, you can see that patient number 1 on the left has got a slightly achogenic rim to a small nodule, and patient number 2 on the right has a hypoechoic nodule, but they're about the same size and they're both superficial. So in compliance with the recommendations of the AASLD, both of these patients had MR for further characterization of their nodules. So you can see that on both of these MR scans, the arrow is pointing to a small area of arterial phase hyperenhancement on the surface of the liver that corresponds exactly with the nodules that were seen on the ultrasound surveillance scans. However, in the portal venous phase, there was no washout, and so therefore this was indeterminate result on both scans. Is this a shunt? Is this a hemangioma? Or could this be an HCC with no washout? So they don't know what the answer is to that question. So subsequently, the patient comes for ultrasound with CEUS. So when we look at the wash-in and the imaging in the arterial phase for patient 1, you can see that that tiny nodule shows peripheral puddles of enhancement. They're discontinuous. They progress centropedally to the center of the mass, and then they show enhancement, global enhancement. Whereas if we look at patient number 2 on the right-hand side, when the microbubbles arrive, you can see globular enhancement, like there's global enhancement of that nodule. So a very different appearance of both nodules. And so when we go on and look in the portal venous phase, so let's come back to patient 1 on the left, and we can see that in the portal venous phase here at 2 minutes, but all the way to 5 minutes, the nodule has disappeared because it has sustained enhancement. So with those peripheral nodules of enhancement, centripetal progression, and sustained enhancement, we know that that is a flash-filling hemangioma and requires no further attention. So, and now if we look at patient number 2 on the right, we see the global enhancement of the mass in the arterial phase. And then at the bottom with our intermittent follow-up imaging at 2 minutes, we see weak washout. This is weak because the nodule has dropped down below the enhancement of the liver, but there's still echoes within from the microbubbles, making it a weak washout pattern. And this is the classic appearance for HCC. So it's CEUS that provides the real-time dynamic capability to differentiate the enhancement both in the arterial phase and the portal venous phase, different from the much more restrictive information from the MR scan. So dynamic real-time ultrasound shows rapidly changing arterial phase enhancement patterns, ideal for the diagnosis of benign tumors. It also shows enhancement in the portal venous phase, with washout having a high association with malignant outcome, and therefore, of course, sustained enhancement having an association with benign tumors. And it resolves indeterminate MRI. So let's go to another case example, a 40-year-old female with increased liver enzymes, and she has a lesion found also on a surveillance ultrasound scan. So as per the AASLD guidelines, she goes for MR as well. So we can see here that the arrow marks on this T1 image a dark nodule. Other imaging showed that that nodule contained fat. So when in the arterial phase, they show hyperenhancement of this mass that they realize has fat content, the interpretation is a probable hepatic adenoma. And although this lesion is small, that is a significant diagnosis. So the patient comes for ultrasound, and we can see the arrow marking an echogenic nodule that corresponds with the nodule on the MR scan. And then on the right, we can see with bubble tracking technique that this lesion has centrifugal filling from the center to the periphery. It has a star-like appearance, and this, of course, doesn't suggest an adenoma. We extract from that AVI clip images at 10, 15, and 20 seconds showing the filling from the center to the periphery, and we recognize that this, of course, at 3 minutes shows sustained enhancement, and this is a classic FNH, not a hepatic adenoma. Again, resolution of an uncertain MR scan. Another patient, a 67-year-old female with no risk factors, but she has a lesion found on an outside routine ultrasound scan. So she also goes first for CT scan on the right and then for MR scan on the left. And both of them show a fairly homogeneously enhancing big mass in the liver with an unenhanced scar-like area centrally. When we look with dynamic real-time scanning, we can see that in fact this also shows this centrifugal filling from the center to the periphery of the mass with a star-like distribution. So this is a vascular and arterial phase FNH-like morphology when we confirm that at 3 and then at 5 minutes, the nodule has sustained enhancement. This is a classic FNH as well, requiring no further investigation. Now let's look at a patient who has a mass on an outside ultrasound with a different outcome. So here we can see nicely the liver with a black mass, and when we inject the contrast, you see the bubbles arrive and the mass is hyper-enhancing. But as we watch, so this is a clip that's perhaps 15 to 20 seconds long. So within the confines of this clip, our mass has gone from being hyper-enhanced to now looking very black. So the clip is looping here. So we inject the bubbles, immediate hyper enhancement, which is transient, and the mass becomes black before our eyes. So at 12 seconds, we have a hyper-enhanced mass, but by 23 seconds, we have weak washout, and by 2 minutes, the mass is completely black. So this kind of rapid washout at less than 1 minute, it is the hallmark for diagnosis of metastatic disease. And this contrasts with those masses that I showed you, the hemangioma and the FNH, where the arterial phase enhancement pattern really tells you or sense to you of what the answer will be. Here it is the rapid washout that is characteristic, hallmark for the diagnosis of metastatic disease. So now let's talk about the contrast agents that we use for doing CEUS. So the CEUS agents are purely intravascular, whereas the contrast agents for MRI and CT scan have a well-recognized interstitial phase. And we will show you that there is clearly an advantage in favor of intravascular agents. So let's just look at this little schematic that I've had for years. So when we look at CT and MR contrast agent entering the vessels, the rate of the enhancement is related to both the arterial and the portal supply to our liver and the tumor. And the intensity of the enhancement, however, relates to the vascular volume and also to the vessel permeability. So if we have some malignant tumors that have very permeable vessels, and particularly if we have a fibrous stroma, we can have a lot of contrast agent pass into the interstitium of the tumor. So contrast that with the microbubble contrast agent performance, where the rate of enhancement again reflects both the arterial and the portal venous supply, but the intensity of the enhancement is related only to the vascular volume. So on CEUS images, we are always looking at signal intensity that is in proportion to the volume of microbubbles in the blood supply. So let's look at a very important example. This is a 67-year-old female who has Hcv cirrhosis. So she is undergoing surveillance ultrasound and a lesion is detected. So the first place she goes is for CT scan. And we can see a vague area of not very hyper enhancement, but a little bit of enhancement in the arterial phase. By the portal venous phase, this enhancement has increased both in its distribution and its amount, but it's a funny looking mass, and it was questioned to be possibly an atypical hemangioma with a recommendation to go to MR scan. So on MR scan, you can see a very unusual appearance again. So the appearance in the arterial phase continues to show this rather nodular peripheral enhancement. And in the portal venous and the delayed phase, there is really not very much change. So there's no washout. We don't know what this is. So this is also reported as an indeterminate result. So the patient is sent for ultrasound and we can see an echogenic mass. The patient has CEUS and we see a thick rim, so arterial phase rim hyper enhancement. And then in the portal venous phase, by just 60 seconds, all of that rim enhancement has completely washed out. And so this is a patient who shows rim arterial phase hyperenhancement and rapid washout at less than 1 minute. And the washout is marked. It's very black washout. And so what does this suggest to us? Not hepatocellular carcinoma. It suggests any of the non-hepatocellular tumors. And this includes both cholangiocarcinoma and metastatic disease. But when we have this discordance, we always think of cholangiocarcinoma. We must biopsy for diagnosis, and this is a cholangiocarcinoma. So now we recognize that, in fact, interpretation of portal venous phase discordance, looking at MR and CEUS together, actually provides very valuable information. So let's look at a case example that reflects this observation. So a 67-year-old male with risk factors for HCC. So on MR, his T1 pre-contrast scan shows a large T1 dark mass. And then in the arterial phase, it shows heterogeneous hyperenhancement. And this enhancement persists in the portal venous phase and in the delayed phase. And so this is a difficult interpretation, MRI indeterminate. So let's look at this on ultrasound. So on the grayscale ultrasound, we can see that there's an echogenic mass in the liver. Obviously, this mass is a big mass and it is hyperenhancing in the arterial phase. And so when we look at our still images, we see that the mass at 20 seconds, the liver has not even completely enhanced, but the mass is hyperenhancing. But by 50 seconds, we see that the liver parenchyma has come up, but the mass has gone down. And so there is weak washout at 50 seconds, which becomes more marked with time. And you can see that washout is a very striking appearance here. So this is classic for us, rapid washout, non-hepatocellular malignancy. Now, if we look at that MR with the CEUS, we can see that the big mass is confirmed on the unenhanced images of the MR and the ultrasound. In the arterial phase, we have that hyper-enhancing mass, again, on MR and on CEUS. But in the portal venous phase, the contrast enhancement of the tumor is still there on the MR, whereas it has washed out black on CEUS. And this discordance suggests to us immediately that we must exclude cholangiocarcinoma. So always think ICC, biopsy these cases, and this is again cholangiocarcinoma. So MRI and ultrasound discordance in the portal venous phase relates to interstitial contrast on MRI, which causes pseudo-enhancement. CEUS, a purely intravascular contrast agent, shows washout with malignancy. So this is a very valuable, this alone I believe is enough to make CEUS an essential component of imaging of liver tumors. So now what about technical advantages of CEUS? Well, the specific software, so this is contrast-specific software that's present on all high-end ultrasound machines. It provides an excellent subtraction technique that removes all background tissue. And the result of this is that it creates a microbubble-only image. And this microbubble-only image provides us with superior sensitivity to the presence of even a single microbubble. So let's look at an example of a scan on ultrasound. So this is a male with Hcv cirrhosis, and you can see his cirrhotic liver appears gray and coarse, and then arrow points to an echogenic, slightly exophytic nodule arising in the liver. So this nodule is well over our threshold where we must confirm its diagnosis. So at time 0, we can see that when we turn on our contrast-specific imaging, so that image at the top corresponds with the image at the bottom. And at time 0, we can see that the gray liver has disappeared and that the echogenic nodule has similarly disappeared. When we look in the arterial phase at 15 seconds, we can see that the liver is already well enhanced and that our tumor now is hyper enhanced, and we can see a feeding vessel coming up to the tumor at 15 seconds. Now we do intermittent scans after we confirm the arterial phase hyperenhancement, and at 2.5 minutes we can see that now the enhancement of the tumor has dropped down below the enhancement of the liver. This constitutes washout, and it's weak washout because there are still some bubbles remaining within the enhanced tumor site. And so what do we know from this? This is the classic enhancement for HCC, arterial phase hyperenhancement at 15 seconds and late and weak washout at 2.5 minutes. And so if we watch the actual real-time acquisition of this, you can see that when we inject our microbubbles, that virtually within seconds, within a few frames, we go from having no enhancement to having very incredible enhancement of our feeding artery, of our tumor, and also of the liver parenchyma. Now, let's go from there and talk about occult tumors. And so I'm sure that all of you are aware that everybody believes that occult tumors are present on ultrasound, and they are present on ultrasound. However, the thing that's very important to recognize is that they can also be present on MRI, and this is not a widely held belief. So let's look at a 69-year-old male with Hcv cirrhosis. So this was done in my department here in Calgary, and one of my lovely sonographers brings me these pictures, a long axis and an axial view looking at the cirrhotic liver, and says to me that there's a tumor in the liver. And I thought that looks like a good guess that there is a tumor in the liver. So we do CEUS and we show that the mass is hyper-enhanced in the arterial phase. And again, at 2.5 minutes, there is late and weak washout with bubbles still remaining, but the overall enhancement of the nodule has fallen to less than the enhanced liver. So this is a classic HCC, and we reported it as such, and the patient went on to have a staging MR scan. But when the patient went for the MR scan, they said, well, there is no nodule and there's no APHE. And so because they didn't agree with us, we said, okay, fine, we have to do something else. So they sent the patient for CT. And again, at the tip of the right lobe, they said there's no mass and there's no hypervascularity. So I didn't realize all this was going on. So it was some months before this came back to me, and we suggested that the patient should have what we call Primovis Scan in Canada, and you call Ceus Scan, I believe, in the United States. So on this scan, which was performed at least 6 months later, we can see that in the arterial and the portal venous phase, there's still no evidence of a tumor, and there's no evidence of hyperenhancement. However, on the delayed imaging, which is the value of doing these imaging tests, we can see that there's a void. And so that, of course, is our tumor. And if we look at it in the same orientation as it was shown to you on the ultrasound, you can see that on the arterial phase imaging, it doesn't show, the nodule's not there on the baseline or on the contrast vascular images. But on the delayed imaging, which you'll get with Primovis or Eovis, there is our tumor. This was biopsy proven hepatocellular carcinoma, not shown on MR for at least 6 months after we detected it and diagnosed it on ultrasound. So what does this show? Well, it shows us that grayscale ultrasound has excellent spatial and contrast resolution. And so we're very good, in fact, at looking for baseline nodules. Furthermore, arterial phase imaging on ultrasound has the greatest sensitivity to detect vascularity of any of the three cross-sectional imaging modalities, and that's ultrasound, CT, and MR scan. Therefore, if a patient has a positive surveillance ultrasound, it's inappropriate to ignore it on the basis of a negative CT or MR scan. So let's talk now about arterial portal shunting. So this is something that occurs commonly in liver cirrhosis. It's a common observation on CT and MR scan. And how does it show? It shows as arterial phase hyperenhancement only. So it doesn't show a baseline nodule on T1 or T2. It doesn't cause restricted diffusion on MR scans. And these are indeterminate because although they could be correctly designated as arterial portal shunts, they could also be hepatocellular carcinomas, in that many small tumors have arterial phase hyperenhancement only before they develop washout. So let's look at an example. So this is a 66-year-old lady with cryptogenic cirrhosis who has multiple foci of APHE. So when you look at her pictures, you can see that everywhere there are these bright foci of hyperenhancement. And so, of course, the person reading this would guess that these are probably multiple shunts, but in truth, they don't know that for sure. However, when they get to the portal venous phase, all of these completely disappear and there's no associated washout. So they're presumed to be shunts. So if we look at this patient on ultrasound, we can see coarse, rather echogenic parenchyma, but we see no nodules on the long axis or the axial view, which I'm showing you here. And then when we come to CEUS, we do perform CEUS based on a nodule, but when there's suspicion of shunts, sometimes we do it without actual focus on a nodule. So we see no nodule and we see no hyperenhancement. So this more or less resolves the issue of the pseudo lesions. And in addition to doing still images, we sweep the liver as here, where we're looking in the axial phase with a suspended respiration, and here looking at the part of the liver in the sagittal phase, as in the sagittal projection as well. And so we look at this in these kinds of sweeps, looking both at the time of injection and in the portal venous phase. Now, let's look at an example. This is a 64-year-old male who has Hcv cirrhosis. And so 2 years after his HCC treatment, he has secondary surveillance with MRI. And there's an observation made that's comprised of arterial phase hyperenhancement only. So here's the arterial phase vibe, and we can see that in segment 4, there's a area of hyperenhancement, and we don't see anything else. And in the portal venous phase, there is no washout, that's associated. So this is a patient who's had an HCC in the past. So the person reading this, I think very correctly said, this looks like a shunt, but could it be HCC with no washout? So they don't know that for sure, so they nicely sent it for ultrasound, and corresponding precisely with the site of the APHE from the MR scan, we see a baseline nodule on ultrasound. And so this, of course, is the focus for our CEUS exam. And you can see in our dual screen projection that we have arterial phase hyperenhancement of that mass in the arterial phase. And then when we look at 3 minutes and 30 seconds, we have late and weak washout. So there's the nodule at the top, the APHE, the weak washout, which is started by 2 minutes on the bottom left and is still there, but much more dramatic on a 6-minute follow-up scan. So this is a classic HCC. And this is another tremendously valuable use for CEUS in that these indeterminate situations arise on MR with regularity. So APHE on CEUS is virtually always performed as a nodule-based exam, so that it's a nodule-based observation. But the observation of APHE on CEUS has more specificity than APHE on CT or MR scan, which may frequently represent shunting, which is not nodule-based. So the demonstration of APHE on CT or MR is an excellent indication for CEUS in the management of small nodules at risk for HCC. So in conclusion, we've looked at dynamic real-time ultrasound showing rapidly changing enhancement regardless of timing. And this is exceptional to show the morphology of benign tumors, and it removes the requirement for more expensive downstream imaging. We talked about purely intravascular microbubble contrast agents for CEUS, which frequently show discordance with interstitial agents for CT and MR scan, which show pseudo-enhancement instead. We talked about occult tumors, and we acknowledge that they do exist, of course, on ultrasound, but we've shown that they exist as well on CT and MR scan. And the excellent spatial and contrast resolution of ultrasound is to our great advantage, and the scanning techniques for CEUS give us superb sensitivity to signals from the microbubble contrast agents. And we talked lastly about the frequent shunting that is visualized in cirrhotic patients on CT and MR scan, which is not confirmed on CEUS. And of course, before we leave ultrasound, we can't ever forget that ultrasound is always a very safe technique. CEUS is a robust imaging technique, which is resistant also to breathing artifact. And today, with such keen interest in safety and money, I believe that CEUS is surely an irreplaceable addition for liver imaging. And with that, I conclude my presentation, and I'm grateful if all of you stay around, and we'd love to answer your questions, and I would love to have some liver questions that we can help you with at the end of Dr. Darge's session. Thank you.
Hello, everyone. I'm Richard Barr. I'm going to talk to you about CEUS for renal masses. Ultrasound is often the imaging modality for evaluation of renal disease. Initially, non-enhanced ultrasound faces limitations in the assessment of focal renal masses and complex cysses, and CEUS in the kidney can overcome all these shortcomings. This is a list of the advantages of CEUS, and I'm not going to go over all of them for the sake of time, and Stephanie has included some of them in her talk, and I'm sure Dr. Darge is going to include some in his talk. What I would like to do is just go over a few of those that really are pertinent to renal imaging. First of all, if we look at the frame rate or the number of images that we collect, for a 3-minute CEUS image, we collect over 5,000 images. CT and MR both collect 3. If we look at slice thickness, less than 1 millimeter for ultrasound, 2.5 millimeters for both CT and MR. Contrast allergies or contraindications, extremely rare for ultrasound contrast, not uncommon for both CT and MR. And if we look at the contrast to background ratio, we have background completely subtracted on ultrasound contrast, where we still have the background present on CT and MR, and obviously ultrasound is portable. And these are what we're going to go through this talk. You'll see the importance of these. When we talk about frame rate, as Stephanie showed in an FNH, things happen very fast over seconds in the arterial phase, and this is also true in renal masses. And oftentimes, what will happen is on CT and MR, if the timing is not perfect, on those 3 images, you don't see the hyper enhancement of the renal tumors. Slice thickness, very critical when we're looking at complicated cystic masses, because the septations have nodules that are about 1 millimeter on them in some cystic renal cell carcinomas, and they're obviously volume average with CT and MR, so you don't notice the nodules, and you can't really appreciate the enhancement. And again, we have no contraindications. A lot of these patients have renal insufficiency, so again, CEUS is an ideal for those patients. And again, when we look at the background contrast, this is really critical when we're looking at interventions on renal masses, which are becoming quite frequent in the method of treating many of these small cancers, that when we do an RFA or a cryo, we can see that there is no vascularity left. It's very hard on CT and MR to exclude a small amount of vascularity. So indeterminate renal masses are a common clinical problem. We see them every day. It is estimated that more than half of the patients over the age of 50 have at least 1 renal mass. And many renal masses are found incidentally during an imaging exam. And a lot of these masses are benign simple cysts, which we can confidently diagnose with any of the cross-secting imaging alone. But there are a lot of other masses that we can't do that. If we exclude inflammatory masses, vascular abnormalities, and pseudotumors, most solid enhancing renal masses are malignant. Complicated cystic lesions with enhancing soft tissue components, excluding the actual cyst wall, are malignant. However, there's a wide range of complicated cysts between the obviously benign and the obviously malignant lesion. We use the Bosniak classification to, in a sense, grade how complex the lesion is to decide what the suspicion of malignancy is. The categories go from 1 through 4, with 2 having a 2 and a 2F based on the number of septa, wall thickness, or calcifications. There is a new classification that came out in 2019, and that classification was redone because there were so many unnecessary biopsies and surgeries on benign lesions. So the criteria actually have changed a little bit to hopefully decrease the need for doing biopsies and surgeries on benign lesions with CT and MR. The new Bosniak classification does not contain a CUS component, which it probably should and hopefully will in the near future. And again, the reason we use the Bosniak score is it gives us a probability of malignancy, with 1 and 2s being approximately 0, 2 Fs 5%, 3s in the literature anywhere from about 31 to 100%, and 4s 100%. And you'll notice that as the 3s and 4 at the present time require either biopsy or surgical resection to confirm that. And we'll show you that using CUS, we can make a significant improvement in patient care by eliminating the need for biopsying of benign lesions. So if we look at pseudotumors, which are again very common and can be seen on MRCT, or more frequently, I think, on baseline ultrasound, CUS allows for accurate characterization of these, such as a column of Bertin or fetal ovulations. A pseudotumor remains isoechoic to normal renal parenchyma in all phases of enhancement, and a medullary pyramid is seen centrally. Ultrasound contrasts are not excreted by the kidney. Therefore, we don't see contrasts in the collecting tubules. So the medullary pyramids, which have much less blood flow than the cortex, will show up as being hypovascular to the renal cortex, and we can usually see them on all images. So if you can see here, let me grab an arrow. This is actually a 20-plus-year-old image, and I show you this because this is really a robust procedure. When we had equipment that was 20 years old, we still got excellent results. The modern equipment allows us to get better quality images, but in reality, the older equipment provided enough information for us to make adequate diagnoses. And here you can see the medullary pyramids, which have less blood flow than the cortex, and here a simple cyst where you can see not one bubble within this cyst, confirming that there's no vascularity and therefore the lesion is benign. With the superior spatial and temporal resolution of CEUS, real-time imaging of the microcirculation allows for resolution of flow within septa, nodules, and cyst walls that may not be visualized on color Doppler or power Doppler or enhanced CT or MRI images. In addition, these are usually small, and it will be volume averaged on the CT and MR. CUS has been shown to be superior to unenhanced ultrasound and contrast-enhanced CT in the diagnosis of malignancy and complex cystic renal lesions and may upstage the Bosniak classification. And now there's a lot of literature that confirms these findings. For solid focal renal masses, they're common, initially detected by ultrasound, but it has a low diagnostic accuracy compared to CT and MR when the contrast is given, and there may be considerable overlap between benign and malignant lesions. And CUS allows detailed assessment of the neoplastic circulation and is more sensitive than contrast-enhanced CT and MR in detecting vascularity and hypovascular lesions. CUS is sensitive in identifying unenhanced cystic areas, necrosis, debris, and hemorrhagic foci within tumors. And we're going to start this. I'm going to go a little fast here because there's a lot of dead time here. As you'll notice as we go, you'll see this lesion, which is relatively indeterminate on baseline ultrasound. We can see the kidney is now filling with contrast. And now you'll notice there's kind of a Y-shaped area with bubbles. And as we go a little further, those septations get thicker and thicker with more and more bubbles with some nodularity. And we have rim enhancement. And as we pan through the lesion, there are areas that are solid. So this is clearly a cystic renal cell carcinoma. You'll notice that in the lesion just to the right of that shows no enhancement and is a benign cyst, which we don't see very well on the B-mode imaging. We performed a retrospective study on about 1,000 lesions from 1999 to 2010, which we published in Radiology in 2014. The patients were 44% female and 56% male, ages from 17 to 95, and we had lesions varying in size from 2 millimeters to 16 millimeters, so basically all comers. And we used ultrasound enhancement patterns to characterize these masses as benign or malignant. Lesions with a definitive diagnosis, meaning they went to surgery, angiomyolipoma had fat on CT, or they were aspirated and found to be benign. We had 306 that we had a definitive diagnosis. 167 of those were benign and 139 were malignant. We had 7 and 12 that we've now followed for over 10 years. And this is the algorithm that we use to classify lesions. If there was no flow in a lesion, we considered it benign. If there was an occasional bubble in a septation, you'll see one little bubble marching through the septation, we consider that benign. Enhancement equal to normal cortex in all phases in the presence of a central medullary pyramid, benign pseudotumor. Echogenic mass with enhancement less than renal cortex, often with a peripheral distribution of benign angiomyolipoma. We did recommend a CT or MR to confirm macroscopic fat within the lesion. Constant flow of bubbles within a fine septation without nodularity. We initially considered indeterminate, but we have now followed all those and they've been benign, so we now consider them benign. Echogenic mass with enhancement equal to or greater than normal cortex without washout, malignant echogenic renal cell carcinoma. Any other mass with blood flow, solid or cystic, as malignant. So a couple of the key differentials that we need to do here. If we look at any Bosniak 2, 2F3, and for that matter a 4, on unenhanced examination, we can see the septations or nodules, but if it's a benign lesion after ultrasound contrast, we see complete black voids. There's no enhancement at all in these lesions. Whereas if it's a malignant lesion, the septations or nodules will show enhancement, which will persist through all phases of the enhancement. looking at angiomyolipomas versus echogenic renal cell carcinomas. The angiomyolipomas, in our experience, have had enhancement less than the cortex in the arterial phase and often had areas that didn't show much enhancement. They kind of look like a hemangioma would look, partly in the kind of mid-phase where it's kind of heterogeneous. And then they will actually, oftentimes we'll see it bright at the very end when we're losing contrast, because the echogenicity of the angiomyolipoma just shines through when we see that. Whereas the echogenic renal cell carcinomas on the arterial phase will show marked enhancement and washout. And with this, we've been able to do a fairly good job of classifying a echogenic mass as an angiomyolipoma or as echogenic renal cell carcinoma. And I'll just show you some. So here is an echogenic mass. And we'll start this clip. And here you can see already that there is significant enhancement and it's greater than the cortex. There are some areas here that are central, which are actually necrosis in this cystic renal cell carcinoma. If we look on the image on the right with this echogenic mass, as we go to the arterial phase, you'll notice that this lesion shows very little enhancement. There's a couple bubbles here and there in kind of a random pattern, and that persists throughout the phases here. So we can make the diagnosis here of an angiomyolipoma and here a cystic, an echogenic renal cell carcinoma. If we look at our per patient results, we had a sensitivity of 100%, a specificity of 95%, a positive predictive value of 95%, and a negative predictive value of 100%. We had 5 false positives, which included 3 oncocytomas, which are benign solid vascular masses. But in our institution, these all come out because our pathologists will not classify them as benign unless they have the entire tumor. And we had 2 Bosniak 3 cystic lesions that showed enhancement, and they turned out that they were infected. And I think what's really key here is the negative predictive value of 100% says we are perfect in saying if there's no enhancement, we should leave the mass alone. The patients do not need any intervention. We followed these for 3 months and none of the lesions changed. And like I said, we reported this in the report, but we've now followed them for 10 years and we have had no lesions change. So we feel that, again, the exam is really robust. And again, if we just add in those for the 3 months that we had, again, our negative predictive value is 100%, our sensitivity is 100%, and our specificity was 97%. So very good. And here is just to show of the confirmed diagnoses, we had a wide range of different pathologies included. So this was all comers. You only need 1 case like this for you to have your urologist decide that CUS is the way to go. The top images are the 3 images that we get in a renal stone protocol. The patient has a lesion that looks identical in the right and left kidney on all 3 phases. But when we do ultrasound contrast, you'll notice that the lesion on the right kidney shows marked enhancement and was a renal cell carcinoma. The image on the left was a benign cyst and needed no intervention. So again, we do very well, and these tend to be what we see with papillary carcinomas. MR with contrast, is there enhancement in this mass? Are the septations enhancing? I would tell you if I showed you the without image, you would still struggle, but you can see on the CUS, this is a blood clot that has no blood flow. The septation shows enhancement, but more importantly, we have all these little round berries that are less than 1 millimeter or about 1 millimeter in size, which we can clearly see with ultrasound and their volume averaged on the MR in this cystic renal cell carcinoma. Again, here's just to show you we've got 3 little bubbles deciding to go through a septum. And again, that's a benign finding. Again, this is a lesion on CT. There was a contour abnormality. I think we can see the enhancement is much better than it is on the CT, but also you'll notice that we see washout of this lesion on the delayed image, and again, a renal cell carcinoma. Again, we use this a lot. Patients cannot get CT. Here's a complicated cystic lesion with some calcifications. On ultrasound with contrast, we can see that there is a component along the wall that's markedly enhancing. And again, this was a cystic renal cell carcinoma. Again, without contrast on the CT, we know that there's a funny looking kidney, but again, we can see marked enhancement of the lesion with central necrosis. The necrosis is not going to have blood flow. And again, notice we can see those medullary pyramids quite well, and make sure you notice those. MR without contrast, upper right, with contrast on the bottom. Is there enhancement? Hard to tell on the septation. But again, when we look at the ultrasound with contrast, again, we can see all these little berries in this web of septations. All of these are little tumor nodules in this cystic renal cell carcinoma. I'd like to show you these. I think these two lesions on B mode look pretty similar except for the size. They both have an area that we would think is central necrosis if this was a tumor. And I'd just like to show you what happens with ultrasound contrast. So again, for the sake of time, I'm going to go a little bit faster here. You'll notice that this lesion, which is in the upper right, now shows significant enhancement with some areas that don't enhance, consistent with a tumor with necrosis, versus this lesion, which looked identical on B mode, which after contrast shows no enhancement whatsoever. And as we get to the end here, we just showed the kidney to show here's the normal kidney with enhancement, and we can see that this lesion has absolutely no enhancement. So when we go back to the Bosniak classification, we looked at our cases in terms of the exam that got them to us for the study. What was the Bosniak score? And again, this was based on the old Bosniak, not the new Bosniak. But let's look at the Bosniak 3s. Again, most places would either biopsy or surgically intervene on these. And you'll notice that of these cases, 73 out of 76 showed enhancement, and they were malignant. We had 3, again, those were the oncocytomas or the infected cysts that showed up. But these obviously needed treatment. But 2/3, 275 of those lesions had no enhancement and were benign cysts, and really could have been followed by monitoring and not require any intervention. And more surprisingly, even the Bosniak 4s that we think have 100% chance of malignancy that go to surgery, 98% of them, we had 2 again, either oncocytomas or infected cysts in that category that needed to be followed, but 56, about 1/3 of them showed no enhancement and could have been monitored and not intervened. And we actually have had several patients that have come to us because they've had a total nephrectomy for a renal mass that was considered a Bosniak 3 or 4 that turned out to be benign. They now have renal insufficiency, and they now have a mass in the other kidney, and people are talking to them about getting a transplant. And like I said, we've had several people come to us to evaluate those, and again, they've all been benign masses. So we can make a really big impact on patients by using ultrasound with contrast to evaluate these masses and classify them as benign, so no intervention is done. We have a little bit of time left, so let's talk about CUS and RFA. So we use this to identify the mass for ablation, know the size very well. We actually monitor the ablation during this. We've trained our anesthesia to inject the contrast as we're doing the procedure, and we can see if there's any residual tumor, and we can treat them at the same time without moving the patient and being able to completely ablate the tumor with high confidence before we leave the room. And again, we use this to follow up the response. Again, because we have such a great background suppression, it's very easy to see small amounts of contrast. So again, here is an ablated tumor that we had as no bubbles at all. And again, here is that on CT, and I would argue this is without, but even if you had contrast, I think you'd have to argue that if there was only small amounts of contrast, it would be very difficult to pick that up when this mass has such high signal intensity. So here's an image from one of our RFAs. I have just done an ablation in this area. We've now injected the contrast. We have a black void here where we've ablated the tumor, but we still have residual tumor here. that's hyper-enhancing to the normal kidney. And we can now replace our needles in here using ultrasound contrast guidance and do an additional ablation. And we can do this as many times as we want. Really, the contrast doses are so small, and this is so safe, there's no worry that we can't give 5 or even up to 10 in an interventional procedure if we need to do that. So renal infarction, CUS is highly sensitive in the diagnosis of renal perfusion defects because of its ability to image the microcirculation. An infarct will appear as a wedge-shaped defect of enhancement in all phases. CUS is more sensitive than colored Doppler in depiction of infarcts, and we can reliably distinguish ischemia from true infarcts, as there'll still be some flow present in cases of ischemia. We can use this in renal transplants, excellent for assessing the vascular complications of renal transplants, such as arterial and venous thrombosis, as well as infarction. It's very sensitive in the detection of active perirenal bleeding because of its high temporal resolution and real-time imaging. And quantitative analysis using low and high power MI techniques have been applied to graphs, allowing for functional indices derived from these time intensity curves and perfusion from destruction and reperfusion. And we can often see very small infarcts in these kidneys that are obviously volume averaged with CT and MR. This was a case from the late 1990s. It was one of the first cases we did. It's a renal transplant patient. He had renal insufficiency. He had renal transplant artery stenosis. My partner did an angioplasty and noticed a blush in the kidney when he did the exam. The patient went on to have a CT with contrast and an MR with contrast, which were negative. And at that time, I was hounding people to send us cases for our research studies. And this patient came to us, and lo and behold, when we injected our ultrasound contrast, there was a markedly enhancing lesion in the arterial phase before even the kidney, which only lasted for about 10 seconds or so, and then became relatively iso-intense. And again, this is why you couldn't see it on CT and MR. The timing was not appropriate, and it was in the isodense phase. We biopsied this under ultrasound contrast. It was a renal cell carcinoma, and then I ablated it, and here you can see again, no contrast, so we had an adequate ablation. We can also use this for renal trauma. CT is really the modality of choice, I think, when the patient comes into the ER, but many times these patients go to the intensive care unit and need to be followed. And ultrasound, because it's portable, is very helpful for doing this in the unit and not having to bring the patient down to the department. Lacerations, hematomas, contusions, and infarcts are seen as non-enhancing areas surrounded by normal enhancing parenchyma. Pseudoaneurysms and active bleeding can be diagnosed. And most importantly, again, this can be done at the bedside. Here's an example. This is actually one of our orthopedic surgeons who shows after the age of 50, you should not play hockey. He got whacked and got a CT, and then there was question, is this bleeding? Is there a mass? It was unclear on the CT. Here is our B-mode ultrasound. We can see there's some debris or something in the cyst, but with ultrasound contrast, there is absolutely no enhancement, no leakage of bubbles, and this was just a complicated peripelvic cyst. With renal infection, we usually don't need any imaging for an uncomplicated pyelonephritis, but if the patient has complicating features such as an abscess or pyelonephritis, nephronia, they can be evaluated with ultrasound contrast. These areas show up as mass-like lesions. They're usually hypovascular compared to the normal kidney. And again, if there's an abscess, we can see a central defect with rim enhancement followed by quicker washout. And again, we can use this to guide placing a needle into the abscess under ultrasound guidance. So to conclude, CUS has a high sensitivity, in our hands 100%, and a specificity of 95% in characterizing indeterminate renal masses. I estimate now that we have done at least 3,000 cases, and to my knowledge, we have not missed a cancer. We continue to occasionally diagnose oncocytomas or infected cysts as being false positives, but that number is very low. And what we really have done is stopped a large number of unnecessary renal biopsies and renal surgeries. Visualization of occasional bubbles or constant flow of bubbles without nodularity within a fine septation of a cystic mass is a benign finding. Angiomyolipomas enhance less than normal cortex, often with a peripheral distribution, while echogenic renal cell carcinomas have a diffuse, intense enhancement with washout. What's really important is our negative predictive value has been 100%. We have followed over 1,000 lesions now for 10 years. None of them have converted to cancer. They may have grown or they may have changed, but they are still benign. We would like to see a large prospective study done so that we can get confirmation so that in the future, maybe if we have a negative CEUS on a complicated cystic mass, follow may not be necessary, or at least at not the intervals we're doing now. The application of CUS findings to the Bosniak classification can provide a valuable contribution to the accurate classification of a cystic lesion. With a new Bosniak classification, we need to get some clarification as to how CUS can fit into that scheme. CUS evaluation of renal masses could decrease the need for CT with associated radiation or MR with its high expense. And CEUS can play an important role in renal mass characterization in patients with contraindications to CT or MRI contrast. As Stephanie has said, this is a non-invasive, non-radiation exam, can be used in cases of renal impairment and obstruction, and can be used in patients with contraindications for both CT and MR. It can help characterize indeterminate lesions, solid lesions, complex cysts, and inflammatory lesions rivaling that of CT and MR, and I would say in our hands much better than CT and MR. And that's confirmed by our urologists who use us as the first line of evaluating these masses. Actually, even in cases that are pretty clearly malignant, they often send the cases to us to do a CUS for confirmation because of cases that they have found it with CT and MR being inaccurate. An excellent way of assessing the macro and microcirculation of both native and transplant kidneys. Here are some references. I would recommend that you look at the state of the art in North America by the SRU. This white paper was published in Ultrasound Quarterly very recently. It's a 39-page document. It goes over how to do the examinations, contraindications for the examination, and it includes almost every organ and what the literature is to support use of that for off-label use. So I think it's a very important manuscript. There are two. There's a short form that will be within the journal, but there's a supplement that just has this. You should be able to find it online.
Good afternoon, everyone. It's such a pleasure to have so many people attending the Contrast Enhanced Ultrasound webinar. I'll be focusing on pediatric applications and particularly go beyond the on-label applications and describe the current advances and future potential applications that may be happening in children. My name is Kassa Darge. I'm the Chief of Radiology at the Children's Hospital of Philadelphia. All this work in my department that I'm presenting is a work of many people who are listed here, and I'm very grateful for all their input. And going in further on, I'll be also mentioning specific colleagues for specific works that I will be describing. So the purpose of, in this presentation, I'll go over a brief background regarding the contrast ultrasound study, and some may have already been mentioned by my colleagues, Dr. Wilson and Dr. Barr already. And I'll focus on pediatric applications and advanced off-label applications. And I'll divide this into 4 routes of application: intravenous, intravesical, interventional, and intralymphatic. So regarding ultrasound contrast agents, we do have 3 contrast agents in the US: Definity, which is primarily approved for adult cardiac imaging, and Optizone, similarly for adult cardiac imaging. And then we have Lumason, also known as Sonovio outside the US, which is approved for both adult and pediatrics. And it's approved for echocardiography, liver imaging, and in children also for urinary tract, especially reflux examination. What do we mean by on or off label? So on label is particularly for the US, if it's approved by the Food and Drug Administration or in other parts by any government agencies. And off-label is it's not approved by the FDA or other agencies, and it's not listed in the FDA required drug labeling information. The publication that I'm citing here is I think one of the best, and I like to cite it many times regarding off-label use. That's a question that arises when you start using contrast ultrasound for different applications. So in this publication, it stated that up to 79% of patients in pediatric age group do receive medications that are off-label, so which means it's not uncommon. And based on and this application is based on the clinical judgment and discretion of the physician. And really there is no need for disclosure if it's used off-label based on the discretion of the physician. A consent is not a must. And eventually it may become a predominant use actually. And also we have to understand that FDA approval process for many drug companies and for many drugs, especially for pediatric use, is a costly thing. So we may not have that approval for certain drugs. And at least in the US, it appears there is no liability under negligence standard when using off-label. So the route of administration in many of these off-label applications is the same as the one that is on label. So you give IV contrast for liver. So you expect the adverse events to be similar, but the position of the ultrasound transducer may be different. So instead of liver, you scan the kidney or you scan the spleen or other organs. If you go to the FDA website, there is clear mention of off-label use, and it states also that the use of marketed product when the intent is the practice of medicine does not require submission of an investigational new drug application. So this is something also explicitly stated by the FDA. What are the main advantages of contrast ultrasound in children? It does seem, for many applications, the diagnostic value is high, with higher sensitivity, with higher increased conspicuity of lesions. Very important for daily work. It facilitates the workflow by being able to use it at the bedside or intraoperatively, or just-in-time examination if you see a lesion or if you have an outpatient that has to be done quickly. Very good. For us in pediatrics, the elimination of sedation or anesthesia is of paramount importance, and in that role, contrast-enhanced ultrasound plays a big role. The real-time dynamic examination possibility has already been shown how it can be a big advantage. In addition to that, in pediatrics, the patient and family experience using contrast ultrasound can be very positive because of the comfort of the examination, and especially if you do, for instance, reflux exam, you can have physiological voiding position. The cost can be lower than CT or MR. Contrast ultrasound has high safety profile. It's non-nephrotoxic and avoids the use of radiation, or completely lowers the amount or eliminates the use of radiation, which is important in a growing child. Technically, you have a high resolution exam, which has been shown very beautifully, in addition to the real-time dynamic possibilities. And especially in low resource facilities or countries, that seems to be a good way to use for various indications compared to getting an MRI or CT. So with all these advantages, you wonder what are the limitations? And primarily their limitations are ancillary stuff, but not really diagnostic. One is really the culture change, changing a non-contrast modality to a contrast one, the need for IV or a catheter, and the need for involvement of more of the pediatric radiologists, especially in the US settings where primarily ultrasound scans are done by sonographers. And the approval status is always a point of discussion. We're very far now. We already have a contrast approved, but it's not for all indications. Some are off-label. So this is always a point that concerns some colleagues. And then there is also worry about reducing CT or MR and thus lowering the profit margin for the department. This is less of a huge problem in children because unlike in adults, we don't have a huge number of patients, for instance, with liver masses that would have gone to MR or CT and now are getting ultrasound. The number of patients is so small that the impact on the profit margin when converting contrast ultrasound may be just marginal or no major impact. Just for you to understand the off-label applications that I'm presenting is in the background that at the Children's Hospital of Philadelphia, we have the Center for Pediatric Contrast Ultrasound. And this was established a few years back to coordinate and support all the advancement of contrast ultrasound in all aspects, and is directed jointly by a pediatric radiologist and also a pediatric sonographer. The impact has been significant because in the clinical practice, we were able to push the fast implementation, and de facto, we do from head to toe for different indications, contrast ultrasound. We have been very fortunate enough to advance research in pediatric contrast ultrasound, both clinical research, translational, and basic science research, and have a number of INDs that are investigational new drug applications or approvals from the FDA, and we conduct a number of studies. And it has been tremendously positive, the number of grants that we were able to acquire. In addition to these, we conduct, before the COVID time, a monthly hands-on workshop, and we were able to train over 200 colleagues and support more than 40 pediatric hospitals in the United States to start a pediatric contrast ultrasound service. This is just to outline the extent of support and collaboration that we have with the Center of Pediatric Contrast Ultrasound at the heart of the contrast ultrasound work at the Children's Hospital of Philadelphia. So starting with the intravenous application, what are the common indications? Tumor, trauma, infection, and perfusion questions in children. Liver examination is on label. All other examinations are off label. So this is a case of a female 6 months old who had a precocious puberty where ultrasound of the abdomen was done. And you can see here the hypoechoic, well-demarcated lesion in the liver, and color Doppler didn't show much color signal within it. when on contrast enhanced ultrasound, you see the lesion that it is enhancing quickly and becoming isoechogenic to the rest of the liver. And if you wait long enough, you see it's getting darker and washing out more and more. Yeah. And with the static images, you see the enhanced one, and the delayed image, you see the clear washout. And the washout, as previously mentioned, the likelihood of malignancy is very high with washout, even in children. And then this went on to biopsy without having to go to MR or CT, and it turned out to be a hepatoblastoma. So we use similarly these charts to categorize all the liver lesions in children too. What are the off-label intravenous indications? So if you do the spleen, that's really also off-label, like this, a male 7-year-old with a bicycle accident who came with a blunt abdominal trauma. Looking at the grayscale, even if you scan yourself, in this case, I remember doing that, you really didn't see a lesion, but when you give the contrast, you clearly see the laceration in this spleen very well. So let me start with the fetus. So this is very interesting, and I want to share this with you. Our surgeons are working on creating what is known as extrauterine environment for neonatal development. They're using a fetal lamp to produce an artificial womb, which is now so far developed that basically in the next year, maybe 2, we will be also trying out these in premature fetuses. So the collaboration our group has with the surgeons who created this is one, to look at the lungs and the lung perfusion. And this is where they scan the fetal lump. The main indication is those with congenital diaphragmatic hernia, where they want to evaluate the lung perfusion. The advantage is, especially going forward with patient, it will be a bedside monitoring, and to use lung perfusion as an additional biomarker to lung volumes. That's the only thing that's currently used to assess the degree of the diaphragmatic hernia and to make some prognosis. So here is an image of a normal fetal lung that you can see beautifully. The vessels, you can see the enhancement is very nice. And then here you see one that is normal, and then you see the hernia on one side of the chest. These are bowel loops, and then the compressed lung here. So you can assess the enhancement of the lung and the perfusion of the lung. And in addition, you can put a region of interest and generate time intensity curves and multiple variables. So the hope is with this assessment, we'll be adding a more objective parameter with regard to the function of the or development of the lung in a fetus that has congenital diaphragmatic hernia. Furthermore, we also use to evaluate the brain. Here also in this setup, and this is with the idea to monitor effects of various interventions. And also now we're working on measuring the intracranial pressure with contrast ultrasound. Again, the advantage is that we can do it in the future on the bedside and also as a non-invasive method. Here is an example of normal fetal lamp brain perfusion. This is, you see it homogeneous. And then if you go on to look in detail, high resolution, you can actually see the single bubbles, and it is possible to track the bubbles within the brain too. This is already being translated in patients, in newborns. We are doing this, and my colleagues have are using this to evaluate hypoxic ischemic injury for the detection and also for monitoring of treatment, particularly the hypothermia treatment. Again, here, the advantage is bedside monitoring of very sick newborn that are hard to transport with all the equipment they are attached to MRI for evaluation. And we have an IND from the FDA, and we are doing this now as a prospective study evaluation. So it's a dynamic examination, and here are serial images of a newborn with the enhancement of the brain. And we usually have a single coronal brain, and then at the end we do a sweep through the whole brain and generate also time intensity curves like I described before. Here are the real-time visualization, how the brain enhances. This is in the midline coronal image. Here you see the basal ganglia. They do enhance much more than the cortex. And so the perfusion ratio, central gray nuclei to cortex, is more than 1. If there is a problem, you'll see that the enhancement and the ratio is not normal. It's not more than 1. It will be less than 1. And here you see the microbubbles filling and enhancing all the structures of the brain. There is a hydrocephalus. The ventricles are dilated, but the ratio is not greater than 1. Look at this. It's less than 1 compared to the cortex. So this is the MRI equivalent for this study. In addition to that, we also evaluate bowel perfusion, especially we're looking into an necrotizing enterocolitis. We also use it for inflammatory bowel disease to monitor the activity. Again, the bedside evaluation ability in the very sick newborn and the ability to frequently monitor is another one. And we also have a dedicated IND for the evaluation of necrotizing enterocolitis in newborn children. This is another example of bowel contrast ultrasound in an 11-year-old female, 2 weeks of bloody stool and abdominal pain. And you see the bladder, a sagittal image of the rectum, the thickened wall. You see some color signals in the wall. But when you do contrast ultrasound, this is now in the transverse plane, you can really appreciate the significant hyperemia of the rectum in this part. And if you look at the static images over time, there is a significant enhancement and a quick wash-in, a transmural hyper-enhancement, a persistent enhancement, and slow washout point to the presence of active inflammation. And the same thing we can do also time intensity curves. Another applications that we are conducting in patients is the evaluation of the hip joint, specifically the femoral head. And this is in the context of hip reduction. We monitor intraoperatively the femoral head perfusion post-reduction. The practice that has been in place is to do in the OR, the orthopedic surgeon does the reduction, and then after the OR, still with anesthesia, the patient goes directly to MRI, and we do a contrast MRI to depict the femoral heads and to tell the orthopedic surgeon the hip reduction is good. There is no reduction of blood flow to the femoral head. You can imagine taking the patient from OR to the MR, and if there is no perfusion, back to the OR. But this one allows to do the study intraoperatively and avoid the MRI back and forth in these cases. And we have also a prospective IND for these ones. So the ultrasound is conducted intraoperatively in this manner. You see the femur, the femoral head, the pubis, and we do it before and after contrast administration. So this is the hip joint. Here is the femoral head. And then you'll see the contrast that is coming, and you have the cartilage in the femoral head. So here is the ossific nucleus, the epiphyseal vessels, you can see them. And so you have a good evaluation of the contrast enhancement of the femoral head. This shows you when you do a sweep, first you do it at one site and then you do sweep, and you can see more of the epiphyseal vessels within the femoral head. So you can tell the orthopedic surgeon that's fine, and the patient can go. The intravesical application, the common indication is for vesico-urethral reflux, and that is on label with urethral pathology. And this is called contrast-enhanced voiding urosonography, or CEVUS. Here you see the bladder after having been placing a catheter being filled with contrast, and you can then monitor the kidney. And you see here in the kidney, there is only reflux in the lower moiety. So it's a duplex kidney with reflux in the lower moiety. And thus you can avoid doing voiding cystourethography, which is a fluoroscopic method with X-ray. In addition, the detail that you can see with contrast-enhanced voiding urosonography is just amazing. Look, the tiny bubbles going into the parenchymal part of the kidney from the calyces. This is intrarenal reflux. And this detail is, you're able to see it on contrast ultrasound and less frequently on voiding cystourethography. Here, there is the depiction of the renal vessel, the ureter, and at times you're seeing the bladder here. So like in VCUG, you can have the whole urinary tract on one image, and you can do all these grading of the reflux also on ultrasound. We evaluate also the urethra. And this is a normal urethra of a male that is just peeing. But then you can see all kinds of pathologies you are able to detect. This is a posterior urethral valve in a male. So this is a complete examination that can replace voiding cystourethography. Another advanced application intravesical is contrast-enhanced genitosonography. So we have children born with different genital abnormalities, like in this female with 5-month-old who had a congenital adrenal hyperplasia and disorder of sexual differentiation. You see the uterus here, the bladder, the vagina here. And when we feel contrast, if you look here, this is the bladder and here is the urethra. But behind the urethra, you see this structure, which is filling with microbubbles. And if you look carefully, you'll see this is the bladder, the urethra, but there is a connection of the urethra to the vagina. So you have a urogenital sinus here. The vagina is connecting here. This is the fluoroscopic image, and this is the contrast-enhanced genitosonography image showing the same thing. We further use this method for interventional radiology, for biopsy guidance, cavity evaluation, enteric tube check, perfusion, and post-intervention. And I'm happy to say all our interventional radiologists use contrast for various of these indications. Like this, a male 2 months with a thigh mass. When they wanted to do the biopsy, this is the grayscale. You couldn't say exactly where to biopsy. Contrast-enhanced ultrasound shows it's the more inferior part that is enhancing. So that's where the money is. So when you are directing your biopsy, you direct to that, and you get your proper diagnosis of infantile myofibroma in this case. And in the last few minutes, I want to share with you one of the newest applications that we are using contrast ultrasound at Children's Hospital of Philadelphia. We have a center for lymphatic diagnosis and treatment. And we began using contrast ultrasound in the lymphatic application. Normally, we do MRI for MR lymphangiography and depict the lymphatic tract, the thoracic duct after subcutaneous injection or the lymph node injection. Here, the indication is when we do the contrast injection for MR lymphangiography, we need to inject the inguinal lymph node. And what we did do is to go to the fluoroscopy room, inject that, and take the patient to the MR room. But this, the ultrasound allows you to guide you to inject intranodal near the MR and avoid having to use fluoroscopy. The other thing is they are using it also to evaluate the patency of the thoracic duct, which is much better seen than on the MR. This is, you see it up here. And the advantage of this, again, the bedside procedure and the conspicuity of the contrast. So this is how they do. They inject the inguinal lymph node in this manner with contrast ultrasound. And then for the thoracic duct, they do ultrasound of the neck. And this is one example. Here, the MR lymphangiography, it's hard to see that the thoracic duct directly, whether it's open, but here you can see the contrast flow in the thoracic duct and be confident that it is patent. And that's what they used for here. And a case where it's actually occluded, here would be the thoracic duct. We don't see the contrast injection, the contrast flow after ultrasound contrast administration, and we can confidently say that there is an occlusion. So I just want to close by saying the contrast agents in pediatrics have now been luckily in the US approved for limited indications since 2016. But since then, the off-label use has greatly advanced, and in centers like ours, we're working on different applications of contrast ultrasound in children. Please do note that the route of administration may be the same, and the risk is based on the route and the contrast agents, and not where you place the transducer to scan. There are several future applications I hope I showed you with potential great impact on pediatric contrast ultrasound beginning from the fetus. Thank you very much for your attention.
So the first question that was asked was, this was from Tucker MJ, who says, many years ago, Dr. Wilson came to the University of Iowa and assisted Dr. Abu Yusuf and myself with starting CEUS. I am curious, in Dr. Wilson and Dr. Barr's practices, obviously all of our practices, if they assist the sonographers with the CEUS exams, or do the sonographers do these without the assistance of the radiologists? And so, Richard, why don't we start with you, and why don't you give an answer to that? So this is about how much does your sonographer do, how much do you do? And so perhaps describe a little bit to start off with the nature of your practice.
So I'm in private practice in a relatively small community. We've been doing ultrasound contrast now for over 20 years. The same sonographer has been with me for all the research studies and now the clinical cases. We've also trained 2 other sonographers over the last couple years. So we have 3 sonographers that can do the examinations. You know, IV starting is often a problem in a lot of places, but because we are a relatively small office, the MR techs, the CT techs, the X-ray techs all start IVs. So there's always someone around, and there are a couple nurses in the department too. So we really don't have a problem. We know we do them on a Wednesday. They're doing them now as I'm sitting here at home. And we don't have any problems with getting the IV started. If we do have problems, we're kind of an independent building away from the hospital. If we do have problems, I'm usually the backup IV starter. Or what we can do is we can call the hospital and ask one of the anesthesia people to come over with a little device they have to start the IV. But Cindy does almost all the examinations by herself. I like to say she usually knows what I want before I know what I want. So she performs the majority of the exams. Ideally, I like to be there and look at the exams. If there is a problem, then I do go in and I do scan occasionally when it's a very difficult case. But I would say greater than 90% of the cases are done without me in the room, and I just read them after they're done. I trust Cindy because she's been around for a long time. She knows when the exam is limited. And then she usually comes and gets me, or if we need to do a second injection, she'll come and get me and ask me for those situations. But in general, we don't have a physician in the room, only if there's a complication.
Thank you, Richard. So Kassa, how about if you tell us about at the Children's Hospital and what do you do with your sonographers?
So, so the Children's Hospital of Philadelphia is a dedicated standalone pediatric hospital. So we are a quite large radiology department. We have a whole ultrasound unit with some 15, 20 sonographers, and all of them are trained in contrast ultrasound. All of them are trained to inject contrast agents. However, for the IV placement, we have nurses. We have a large group of nurses, a whole sedation unit with some 90 nurses. So they go to the sedation unit, they get the IV line and come for the examination. Our sonographers prepare all the examination, do the primary scanning in most of these studies. We ask the radiologists to go in and check, for instance, if multiple lesions are there, what lesions, or if it's contrast ultrasound to come in at the time of the contrast injection. So primarily, a lot of the pre-scan is done by them. And some of the post-contrast scan, either they do or they ask the doctor, depending on the question, to be in the room. But they do show it to the radiologist before the patient goes.
Thanks, Kassa. So I work in a large tertiary institution and have a small ultrasound department that's focused on CEUS. And I quickly realized that to expand a practice in that kind of hospital environment, that it required more than just me to be able to do contrast ultrasound. And so certainly I believe that the sonographers who participate must show a dedication, as Richard's young lady has done, obviously. But with considering changeover and maternity leaves and things like that, we've had a much greater exposure to more people. But I do believe, I think the sonographers in North America are very, very focused on excellent participation and excellent contribution, and they love to be part of a CEUS department. And so certainly I now have 4 or 5 sonographers at any one time who are very capable of they do the preliminary scan, they come to me with a plan for exactly what they're going to do. They don't do scans when I'm not in the department, so I am there, but looking at obviously more than one scan at one time often. And so the sonographers, yes, big role for them. And I think that it's not a job for a whole department of sonographers. It's a job for those dedicated and focused on doing CEUS. That's great. Thank you. Thanks for the question. Now,
Stephanie, you know, I would add too that, you know, our experience is all the way from a small private practice to a tertiary center. So really, there's no reason why any department shouldn't be able to do these.
no, that is a great comment. And actually, Richard, I'm sure that you and Kassa would both agree with me about this because you two join me in this role. I think that for CEUS to be successful in an institution, it's important that someone on the physician side champions what we're doing. So in other words, I don't think an ultrasound department will grow on its own with sonographers doing CEUS unless someone champions it to get the clinicians interested, to get the support of everyone so that that can be a successful venture. But no, you're absolutely right. There's no reason why it can't be really in any environment in which we place it. That's a great comment. Thank you for that.
Stephanie, if I may add to that, I think what you say now is absolutely important. And this is something I really pushed from the beginning so that the contrast examination would not only stick on me, but are spread out to everyone. So the way we trained our pediatric radiologist is to create what we call a buddy system. And when one does exam, calls another one to teach. And over time, everyone was able to learn. So in our body division, body imaging division, we have some 25 pediatric radiologists, and everyone does contrast ultrasound. In addition, the colleagues in the division of interventional radiology, which are about 7 people, all of them do contrast ultrasound. So it's not dependent on one doctor, but spread to everyone. So that really supports the widespread use of this modality.
I know, Kassa, I acknowledge you've done an exceptional job, but that doesn't remove the necessity for someone to still champion the cause.
Yes, yes, of course. Yes, that's definite.
That's absolutely true.
Yeah.
Now, a question that I think is an important one is, what have we experienced in terms of patient side effects? And so certainly none of us spoke about this today because I asked all of the presenters to talk a little bit outside the box, so about things that you're not going to just have learned at all kinds of previous educational programs before. But safety of the contrast agents is indisputably a great component of doing CEUS. And so certainly I've been doing this full-time pretty well since just around 2000, and I believe Richard has, and Kassa, you have been doing it for a very long time as well. And I'm quite sure, I will say very comfortably that certainly we have minor adverse events, but I have not at this point had any major adverse event in spite of the fact that we inject up 20 people a day, not on just one day of the week, but every day. And so it's a great safe thing. So Kassa and Richard, throw in your 2 bits about this.
Your video is off, Stephanie. Please switch it on. Yes.
Yeah. So again, we've been doing these, we probably average about 8 a week for the last 15 years. And I would say that we see some minor reactions, and people complain of back pain, headache, or nausea, maybe, but it's usually gone within a minute. I would say that I remember 3 people that their symptoms, which were mild, persisted at the end of the exam. And then we had them go and stay in the department. The nurse did vital signs on them, and we watched them for another 20 minutes, and they resolved. So we've never had a significant adverse reaction. We are prepared if it does happen, but we have not had one. Clearly, we have many more reactions with CT and MR than we do with ultrasound contrast.
It's also my experience, and I've been doing contrast ultrasound since the mid-90s. And in children, both intravenous or intravesical, I can't remember where we had a major event or we needed to use a code cart. I think safety profile is potentially even better than in adults. But I do have to say that there are, for instance, allergic reactions described in the literature, even 2, 3 in children. So when we started the contrast service, we added a code card in the ultrasound unit, which did not exist before, just to be on the safe side. We have never used it here, but there are these rare instances described. So we have to be vigilant about that and not disregard that we are really using contrast ultrasound, contrast agent, even if it's for ultrasound.
No, Kassa's last point is really absolutely essential. So if anybody does want to venture out, as Richard has, into a private office setting, you must have a crash cart. So we have one right across the hall from us, but it has happily stayed there ever since it was put there. And so we've never used it, but you must have it. And the other thing that I think is a wonderful thing to have is oxygen on the wall, because any patient who just makes any comment about anything to do with, oh, I don't feel quite right, just a couple of puffs of oxygen and they seem to restore completely. But that's great comments from everybody. Thank you. Now, Kassa, here's a comment for you. From Lucy Kramer for Dr. Darge, how does the sometimes considerable patient motion, especially for younger patients who may have also be crying, affect the success of CEUS? So actually, before I let Kassa answer the direct question to him, I will tell you that this is actually a very, very wonderful positive for ultrasound, in that if you do liver exams, as I do, or any other kind of body exams, and they have MR study, never a week will go by that we don't have at multidisciplinary rounds cases that have failed MR examinations because patients do not suspend respiration during their exam. So apart from crying, just breathing can destroy MR scans. And CEUS, by comparison, first, we have a better method or a better capability to communicate with the patients, even small patients, and they understand better about staying still. But in addition to that, quiet breathing and even considerable motion does not destroy an ultrasound scan. So we have a very, very big advantage in terms of motion artifact, which destroys MR almost completely. So, Kassa, you answer about the children.
Yeah, I mean, you mentioned it. Those of us who do pediatric MR know the struggle with the motion artifact and how much anesthesia and sedation we use to reduce that. Actually, the blessing of contrast ultrasound is you can do it under motion. I mean, we don't ask the patient to hold their breath or so. We do it while they are breathing. You can move with the transducer and follow the lesion. So that's really a great possibility of contrast ultrasound. If there's excessive motion, one thing that might be disadvantages is if you're doing a dynamic scan and creating a time intensity curve. Sometimes you have issues if it's so much motion that it's out of the plane. But otherwise, for diagnostic purpose, that is not a major consideration. And that's actually one of the major advantages being able to do contrast ultrasound in the setting of motion.
Great, that's great. Thanks, Kassa. So this question, I think Richard would love to answer. So from an anonymous attendee asked is everyone billing for contrast enhanced ultrasound in both on and off-label uses of the contrast? So Richard, over to you.
Yeah, so in January 1st of 2019, there was a CPT code. The FDA and the CPT code writers are not the same. They're completely different. So the CPT code people have made a code that is agnostic of agent or of organ. So you can bill for a CUS study on any organ or any of the 3 agents that are approved for use in the United States for a cardiac or abdominal. And I just checked recently, and I thought we were getting paid for about 85% of our cases. Medicaid, I think, was not paying, and some of the PPO Medicares, I think we were having problems. But all of the other players have been paying. The reimbursement is actually quite good. We fought for the CPT code for probably 10, 15 years, and they finally approved it, and they gave us a very good RVU. If I remember correctly, it's 1.6 something. So it's actually almost as close as a CT and an MR for reimbursement. And you can bill for the unenhanced examination if it's done according to the CPT code guidelines.
Yeah, thank you, Richard. And so I'll just make a comment here. So obviously I'm a Canadian and I don't use your fee codes, but in the United States, I've recognized always that the billing system is an essential part of practicing medicine. And so for us to go forward, I think that having that very favorable fee code is absolutely just, it's an indescribable benefit. And so certainly it is, it's very generous. It allows you to bill for multiple injections. It allows you to look at any organ, and it really, really tells the story more how it is than what happens in terms of the FDA regulations about what we can and can't do. And maybe at that point, we might also just make the comment that was made very strongly in the presentations, which was terrific, is that certainly off-label is not illegal and it's not bad. And so I know that Richard and Kassa and I all do tremendous percentage of our work is off-label. Yeah. And so those are both important points.
I just want to add, even in the pediatrics, off-label is a clinical indication. So you that is paid, all the on and off-label ones. For research studies, you need grants to pay for that, but for the clinical off-label ones, those are part of the regular payments.
Now, the first question that came in, we'll just deal with quickly. So from an anonymous attendee, do you generate quantitative analyses with time intensity curves on CEUS studies? And so I can just address that first of all, and I know Richard and Kassa will both address this as well. So time intensity curves and quantitative analysis of CEUS is a very big thing and has its own committee in Kiva from the RSNA. And one of the ongoing problems with doing these quantitative analyses is that there is a difference between manufacturers of the result that we get. Now, is the generation of time intensity curves and the quantification of blood flow valuable to us? Absolutely. And the two most celebrated uses, of course, are in oncology patients where tumor response is evaluated with quantitative curves on CEUS. And of course, in the inflammatory bowel arena, where inflammatory activity can also be quantified. But at the moment, there are some holdups that are related to lack of standardization of this technique. So Richard or Kassa, over to you.
So I would mention that there are some preliminary research that doing time intensity curves of renal masses may be able to distinguish papillary from clear cell. And the reason that that's important is papillaries tend to be relatively benign and could be followed, where clear cells are more aggressive and need to be followed. So preliminary work on a relatively small number of patients yet suggests that using time intensity curves, we could evaluate renal carcinomas and select out which are going to have a favorable outcome with just watching versus those that need more immediate treatment because they're more likely to metastasize.
So I will add there. So of course, what Richard is alluding to is that we now guess which are clear cell and which are papillary, but we do it on a subjective evaluation of what's happening. And of course, in the liver, we do that all the time. So the same could be said for generating time intensity curves to look at, you know, is there in fact a little hyper enhancement in the nodule that you're looking at? And so yes, there are great potential uses, but at the moment, I think we're held up though by the fact that we have not less than standardized equipment available.
Yeah, in pediatrics, it's primarily for research at the moment.
Yeah, but good. Now, someone asked us, does anyone have colleagues in emergency medicine that use CUS in the emergency department with POCUS? And I'm not sure if anybody would like to answer that or not.
Yes.
I'm throwing it out there.
Yes. Actually, on my first slide, the name of my our ED colleagues was included. We have a very strong collaboration with the emergency medicine division, the pediatric emergency. We support their point of care ultrasound. We have together a large grant to evaluate blunt abdominal trauma. We work together on that in children. And also we have an additional grant where we work together for the evaluation of blunt abdominal trauma, specifically in child abuse. And so the hope is that some of the indications, especially like trauma, will be also part of a point of care ultrasound, and in the future is sort of part of the pathways for evaluating these children by POCUS in the ED.
You know, I just would like to add that a lot of the POCUS ultrasound machines are not as advanced as the ones we are using. And although they may have contrast, they may not be as accurate as our systems are. So I think it's really important, if you are going to do this in the ER, you need to have a high-end system that can evaluate the patient appropriately. A lot of the smaller systems may have contrast, but their ability to see the bubbles is decreased. And in a lot of these things, we're looking for very small areas of enhancement that could easily be missed with that inferior equipment.
And another question, anyone using CEUS for aortic graft leaks? So I'll speak to that actually. So when I was in Toronto before I came to Calgary, that was in 2007, I was totally hooked on doing CEUS for aortic graft leaks. So since I've come here, this specialty, the vascular surgical specialty, is not in my hospital. And so I don't do it. But yes, the people that are in that institution, they use it regularly. And so I will add that even my brief exposure that I had in prior to 2007 is that this is a great, very, very, very excellent technique for looking at aortic grafts, especially when you consider the age of the patients and the status of their kidneys. And of course, currently they've been having CT scans for surveillance. And so of course, this is much, much more optimal to do this with CEUS, and the results are superb. Now, so an anonymous attendee asked us, do sonographers require physician orders for the contrast administration, or are standing orders in place for the discretion of the sonographers to use based on their judgment?
So we need to have an order for anything to be going on in the department. And it usually is not from the radiologist. Our center requires us to get it from the referring physician. One way around this is that what we sometimes do, particularly in breast imaging, is we ask them when they do their prescription to say ultrasound liver, contrast if indicated. And that will allow us then to go ahead and do it if, when we look at the non-contrast study, we think that they're going to have a contrast exam would be helpful, then we can go ahead and do that. And that's kind of the way around that. And I think that some places have actually placed that in their ordering program, that the ultrasound abdomen is now ultrasound abdomen contrast if indicated. And that allows us to go ahead and do that at the time the patient's there.
Yeah, that's great, Richard. And I think that answer is terrific. And so I obviously have a different regulatory situation than any of you have, but certainly that's what we have. Our orders come for CEUS. So it's not a question of getting an additional order for CEUS. It's a question of using your discretion for whether you use the order or not.
In pediatrics, it's the same as Dr. Barr explained. Yeah.
Now, Kassa, maybe we'll end up with a question that's for you. question on CUS in fetal lungs. Is the blood flow visualized in these images because the lungs are not aerated? And can this be translated to extrauterine lung exams?
Yes, you saw the beautiful perfusion of the lungs because they were not aerated. The same application goes if you have pathology of the lungs outside the fetus. Let's say if you have atelectasis, pneumonia, abscess, you can use a contrast ultrasound for evaluation. And that is also what it means, the non-aerated part. That works. But to see the whole lung as this, it's only possible in the fetus.
You know, I will add in our age of COVID-19 that we accepted a paper in JUM over the last couple of months that the Europeans were using this in patients with COVID pneumonia and injecting it and seeing if there was perfusion in those atelectatic areas or infected areas. And if there was no perfusion, they were making the diagnosis of pulmonary emboli. And this way they were able to do it in the intensive care unit and not have to go down to get a CT with contrast, which I thought was a very interesting application of this. But obviously you have to have the consolidation to be able to visualize this.
No, that there is no doubt that COVID has made a new application for ultrasound of the lung for certain. So I think that we're coming to the very end of our time. And so I would like to thank Richard, Barr, and Kassa for their wonderful presentations. And I believe that this was a really exceptional webinar and I enjoyed it very much myself. And I'd like to thank both ICUS and the AIUM for making this a possible webinar. And I'd like to say that I believe that for this, our first venture as a webinar, that this was a very successful venture for us, and we're happy with the outcome. And so in 2021, we are planning more combined AIUM ICUS endeavors. And I'd like to thank our audience, just a great audience and just great questions. I know I didn't answer them or ask them all, but I'm appreciative to receive them. And all in all, I think it was just a great event. Thank you all.